So I'm going to be talking about peri-tonsilar abscesses, and I think there was an intro earlier, but yeah, I'm also one of the primary care ultrasound fellows at Indiana University. All right, so this was a case that was in our outpatient clinic I had with one of the residents. It was an 18-year-old male. He came in with for some recurrent visits concerning some tonsillar swelling and pain that he's been having. When we examined him and took a look at him, he had this right-sided tonsillar swelling with some exudates. He had left-sided uvula deviation. He was non-toxic appearing. He was under no distress, but he did have some difficulty in swallowing. So we went ahead and did a rapid strep test. It actually came out negative. But over the previous 8 months, he has received a couple rounds of antibiotics, and this is actually the third visit to the clinic. So with that, I was thinking, and the resident was thinking as well, that this was most likely an abscess, but we just didn't know. We didn't have the imaging. So we were he was a little confused as far as where to go as far as the next step. So this is usually what you would see. This wasn't our actual patient. But as you can see here, you got this unilateral swelling over here. You got some uvula deviation. And then what you're usually thinking is the difference between an abscess or a cellulitis. So, because this is a ultrasound interest group, I mean, of course, I'm going to target on the ultrasound, but there are some other imaging modalities and some other physical exams that people approach to actually draining some of these at times. So if you look at the bottom here, I actually showed the sensitivities and specificities when it comes to physical exam, when you're able to actually diagnose and treat this in comparison to CT, and then using an intraoral ultrasound probe or a transcutaneous approach. And as you can see, just by physical exam, the sensitivity and the specificity are rather low. CT is high, but again, with CT, you got to think about the timing, how long a patient is going to be sitting in the ED. Also, the radiation. This is in the neck. I mean, so it's a lot of radiation that you're going to be given there, as well as to the thyroid. And then for active imaging guidance, ultrasound is going to be there. You can't do this under CT imaging or any other imaging. So that's what also makes it that much better. It helps expedite it so you can get the patient in and out. And then, like I said, the active guidance as well. And in one randomized prospective study, actually, they were looking at a clinician's diagnostic accuracy for a peri-tonsillar abscess using an intraoral probe, because this is where most of these studies are actually done with versus a transcutaneous approach. And they did that versus a clinician using landmarks. And they actually found that the accuracy as far as the diagnosis in comparison to the two was 100% for the intraoral use of the ultrasound versus about 64% when it came to the physical exam. And with that, the ultrasound actually led to a 7-fold decrease in subspecialty consultation and further imaging versus the landmark-based approach, which required over 50% of their patients to either be further consulted down the line or have additional imaging, including CT scans. And like I said, so although there are limited studies in terms of the transcutaneous approach or transcutaneous diagnostics for this, there was also a few other studies that showed that when a patient either has trismus or something and you're unable to actually get the intraoral probe into the mouth, the use of the transcutaneous ultrasound did diagnose 100% of cases. So it shows its utility there. So this is your intraoral versus a transcutaneous, and I mean, just by looking at this, I mean, you can, it already seems pretty uncomfortable just to have that intraoral device in your mouth. These patients are sometimes in a lot of pain. They've got trismus. They're unable to open their mouth very wide. So the use of an endocavitary probe is something that may not be so user-friendly. And just one thing with the endocavitary probe, always make sure that you're saying endocavitary and not like a transvaginal probe, because a patient hearing transvaginal probe going into their mouth probably isn't going to be the most, satisfying thing to hear for the patients. When you do these approaches, I just have a couple images that are comparing the normal anatomy versus what you would see for a cellulitis versus an abscess. And so for the normal anatomy here of a tonsil, they range anywhere from about 10 to 22 millimeters. They're either triangular shaped or they're oval in appearance, and they've got this just homogeneous, like low level echo texture where you can see maybe a little bit of something in there, but the size of it is pretty good. It's pretty uniform throughout the entire structure. And so it's comparing A to B. So this is, as you can see the footprint here. So this is going to be your endocavitary probe. And then this probe here is going to be a linear probe that they used. And same thing on the linear probe side. You can see this over here as what the normal tonsil looks like. And then I think they have it start over here just for anatomical purposes. This is the oropharyngeal cavity. And then this, I believe, is going to be your submandibular gland. And then this would be probably most likely your internal carotid. Now versus a cellulitis that we have down here. So for a cellulitic tonsil, these are going to be enlarged. They're going to be in excess of 20 millimeters. They're going to have this homogeneous, or sometimes you'll have this striated texture within the tonsil itself. And when you do see that, likely it's going to be considered a cellulitis. Over here for the linear probe, this one is comparing a normal tonsil to a tonsil with cellulitis. And as you can see here, it's got this little bit of echo texture in here. Little striated in appearance, can be a little difficult to tell if it's maybe your first or second one, but with a little bit of practice, the identification of it is pretty easy afterwards. Then you have your peri-tonsillar abscess. So for the abscess, again, you're going to see an enlarged tonsil over 20 millimeters. And these are going to have a heterogeneous echo texture, or they're going to have this cystic appearance. And when you see that, this is typically going to be what a peri-tonsillar abscess is going to look like. And also, it's just something to be aware of. These abscesses can often kind of either distort or they can displace the tonsil either medially or caudally. And regardless of what the echo texture really is, even if you're seeing these little striated lines where you're thinking, oh, maybe it's a cellulitis, but if you see any type of mass effect, it's usually always going to represent an abscess in that location. And one thing that you can always do too, if you're unsure with what you're actually looking at, always go over to the contralateral side of the neck and take a look there just for comparison purposes. So I'm really going to kind of, I guess, focus in on the transcutaneous approach versus the intraoral approach, because the intraoral is the one that's pretty much been studied and been laid out there for a while. This transcutaneous approach was kind of brought to light, I believe it was back in 2018. It was a professor from MGH that kind of came up with this approach. And so what you do here is you can either grab a curvilinear probe. The maker of it said he actually prefers the curvilinear, which is what they have right here. Marker is going to be posterior, and the transducer is going to be placed medial to the angle of the mandible, and you're just going to direct it posterior superiorly towards that tonsillar fossa. And what you can also do is just ask the patient just to point specifically where they're most tender or where the pain is most, and then you can throw the probe onto that area and then kind of look around. And then, like I said, it's always good to kind of evaluate both sides. So go ahead and take a look at the contralateral side as well. And here is kind of what you would see. So so the images are flipped here. So what you see is what you would actually see on your ultrasound imaging. So in order to actually locate this, if this is something that you've never done, what you would likely do is go in, put it to the medial side of the mandible, try to locate the vascular structures first. Most of the time, we're able to see those easily. Try to find your internal jugular vein and the carotid artery. You want to go ahead and just fan the probe up cephalad a bit, and then you would see this structure that's going to be just medial to the oropharyngeal cavity, which is going to be this hyperechoic structure that you're going to be seeing here. This is the tongue, this is the airspace, and then I kind of just highlighted everything over here just for visual purposes. So you can see the abscess over here. You've got your oropharyngeal cavity, and then you have your internal carotid artery right there, which is probably, I mean, less than maybe half a centimeter. And so one thing when you do these abscesses, and this is just any abscess in general, you always want to throw color flow. And you want to throw color flow, one, in this case, because of how close these vascular structures are, so you can identify them. But then also you want to do it because you don't want to accidentally diagnose a potential pseudoaneurysm as an abscess and put a needle in there, because that would not be a good idea. So to kind of help with the procedural planning that you would do if you were to drain these abscesses, go ahead and obtain measurements. And you want to obtain measurements in 3 different orthogonal planes to help manage that. And as you can see here, the measurements that they got was about 3.4 centimeters by 3 by about another 3 centimeters. And as far as the aspiration of the abscess, one thing, again, the vascular structures are in very close proximity of the actual peri-tonsillar abscess that you'd be going for. So ensuring safety is of utmost importance for these cases. And there are several different approaches to this. One is what you can do is you can actually, once you get the measurements, you can figure out where you're at. And you can do this thing called a cap needle approach, to where you would go ahead and take the cap off the needle, see the distance of the peri-tonsillar abscess itself, and go ahead and just snip off the top, to where no matter how far you go, if that end cap ends up going flush up against the abscess, you're not going to end up anywhere near these vascular structures. There's another alternative approach, because sometimes some people say these caps are actually pretty hard, and sometimes when you do cut them, they can actually be jagged, or there can be some kind of pieces hanging off a little bit, and some of them can fall, potential aspiration for the patients, or just the jaggedness of itself can be very uncomfortable. So an alternative approach is that you can grab one of these little pediatric vacutainers, cut off the cap, right? Probably right around here. Go and take the cap off, cut it off. It's rather soft and pliable, so you'd be able to insert the needle through the backside of it, and then this backside that would sit flush up against the abscess is smooth, and it's not going to have any jaggedness or anything like that to bother the patient any more than necessary. And then when you do these, of course, anesthetic is something you do want to do. I mean, I'm not going through like the full approach or the full abscess of the aspiration itself, more just the identification and knowing kind of the setup for this. But good options for anesthesia, you can either use just some localized, like some benzocaine spray, or you can also use some nebulized lidocaine, and then you want to put a little bit of just local anesthetic, lidocaine with some epi into that as well. So they coined it as the telescopic submandibular approach is kind of what they've named it. I have a little video here, so I'm just going to play this so y'all can watch it. So again, this is dynamic. So it's kind of the only way that people can go from doing the needle in a different plane than what the ultrasound actually is. So when you do have the ultrasound kind of set up underneath the submandible, you want to kind of imagine when you go into the oral cavity, and when you keep the oral cavity open, you can either use a speculum, or you can use like a tongue depressor as well. With a light would also kind of help sometimes. But when you do have the ultrasound in this place, you're imagining this plane that you're going to be meeting both of them on. So when the needle does come into the mouth, you can kind of manipulate the probe itself, and you'll kind of find the plane and match them up together. So I'm going to play this real quick. And so what you can see here is that right now he's putting some lidocaine into the abscess itself, he probably went a little too far in that they wanted him to actually put kind of the lidocaine on the outer surface into the actual tissue, then into the abscess. But you can see the abscess kind of swell up a little bit with some of that lidocaine. And again, you're seeing this in live, so you're able to identify where the needle is. You can see the vascular structures. And so the lidocaine is in. He used probably a 25, 27 gauge needle, pulled out, put on a larger gauge needle, most likely an 18 gauge, because you never know just how viscous the material inside the abscess can be. And now he went ahead and is actually going into the abscess, and you can see, I mean, the abscess is collapsing, and you're seeing this in live view. You're able to watch all the contents of it come out. You're still visualizing the needle tip there. You've got your vascular structures over here, everything's safe. And that's it. I mean, the needle tip's still there. I stopped the video, but you can kind of see right there as the entire capsule pretty much collapsed. One thing that you can do also is keep the needle capped. Don't cut it yet at this point. And what you can do is try to help set yourself up is by going in there and going and pressing right up against the abscess itself, so you can see that in real time, and then you can go ahead and cap the needle and do the approach. And here's just some final tips. Again, the whole thing with the transvaginal probe, just try to never say that when it comes to these type of procedures. Always say endocavitary. And then if you're unable to distinguish between like an abscess or the cellulitis, when you are using the transcutaneous approach, if you do have an endocavitary probe, it's great for diagnostic purposes. So you can go ahead and go in there, and you can use the endocavitary probe to go right up against the abscess itself. You can press on the abscess, which we do for most abscesses in general. And when you do press on the abscess, you can get that swirl sign, which kind of tells you, hey, this is definitely an abscess. And then at that point, you can switch back to the transcutaneous approach or the curvilinear probe, and then do the procedure that way. And so, like I said, they coined this as the telescopic submandibular. You can use either a linear or curvilinear. Likely, you will need assistance with this. You'll need somebody in holding the probe. They did say that probably after a little bit of practice that you may be able to do it yourself. But that's if you don't actually need some other tools in order to help keep the mouth open or the tongue out of the way while you're inserting the needle for the aspiration. And then again, regarding the vascular structures, make sure to plan the approach with that fully capped needle because of the safetiness of that in terms of the vascular structures. And then again, you're going into the mouth with a needle. Patients can either be cooperative, patients can sometimes either syncopize on you, they can just have a knee-jerk reaction and end up either moving their head one way or the other, and you don't want the needle accidentally just going into areas it shouldn't. And then in general, again, just regarding any abscess you see, always use color, just in case there might be a pseudo abscess in that area. And then communication is key in these type of things, especially in the mouth where the patient isn't going to be able to voice any type of concerns or anything. So when the patient's mouth is open in these cases, if they need a signal to you or they need to say something, they do get like these secretions in their mouth. You can give them a like a suction. They can have the suction to where they can use that as needed. You can also have them use that suction and maybe like raise it up as a signal instead of them trying to talk or them trying to move while you're trying to insert a needle. And that's just some tips, just some safety things. Just to kind of be aware of and keep in mind when you're doing these type of procedures.